Good afternoon, ladies and gentlemen. Can you hear me? First of all, good afternoon, and I would like to appreciate the organizing committee for the invitation to discuss some interesting interstitial lung disease cases today. And I would welcome the faculty. Professor Athol Wells. It's my great pleasure to introduce him and to discuss these cases with his expertise. And then Dr. Bhavin Chunk Arya, he's a consultant radiologist. He's known to us for a long time. And also it's a great pleasure to discuss our radiological aspects of these patients with him. And then I'd like to welcome Dr. Ramani Punchiheva, consultant histopathologist at the National Hospital for Respiratory Diseases. So our main objective of this MDT discussion is to introduce how clinical, serological, and pathological and radiological investigations can be combined in a multidisciplinary context to diagnose and manage interstitial lung disease with confidence. So we have two case studies selected carefully. And the first case study, I'd invite Dr. CMD Selvaraja. She's a senior registrar in respiratory medicine at the National Hospital, Colombo, to discuss or present the first case, please.
Yeah. This is regarding a patient, a 66-year-old married woman from Ratnarana, who has been investigated for shortness of breath and cough since 2015. She has undergone an HRCT chest done in 2016, and surgical lung biopsy has been done in 2017. By the time, her ANA and rheumatoid factor were negative. She has been diagnosed with diabetes, hypertension, and dyslipidemia. She's a non-smoker. There has been no organic or inorganic dust exposures, no exposures to pneumotoxin medications at the onset of the disease, no connective tissue disease symptoms at the onset of the disease. Her general examination revealed no clubbing, no peripheral stigmata of CTD, and respiratory system, she was tachypneic, bilateral occasional rhonchi were there, and there has been bilateral fine end respiratory crackles. Her musculoskeletal examination was unremarkable, and cardiovascular, abdominal, and nervous system examination were unremarkable. And her lung function test showed restrictive abnormality. Thank you.
Then I'd like to invite Dr. Shankara to discuss the CT scan. In fact, she had a CT scan in 2016, but we don't have the records, unfortunately. So I'd be delighted if Dr. Shankara could discuss the CT scan of in 2020.
So you'll just run the video, right? Does your, oh, it doesn't work from that. Do you think it'll work there? Can I? Yeah, okay. Then
Thank you.
Right, so we've got a video that goes from the apex to the base. Okay, I'm not able to control this very well. Okay, so let me just, as it goes on, I will take a minute and do that. And you can pretty much see that there are reticular opacities. You can see some traction bronchiectasis of the non-dependent upper lobes. But as we go inferiorly, you'll see that it is a lower lobe predominant disease with reticular opacities, some traction bronchiectasis, and no significant honeycombing. And if we can freeze it here, I think this is a classic subpleural basal predominant disease, telling us that there is a fibrosing ILD. There is a little bit of ground glass, so that doesn't fit in very well. But overall, this would be a pattern that we could call either a probable UIP/fibrosing NSIP pattern, and we wouldn't really know which one it is, and then I guess everything else would depend upon the history, examination, and other parameters.
And this patient had a surgical lung biopsy in 2017. I'd be grateful if Dr. Punchehua could discuss the surgical lung biopsy.
Histologically, its overall lung architecture has distorted. That means there are various variable fibrosis and inflammation, especially in the interstitium, with some dilated air spaces, and all are lined by the reactive pneumocytes, with some occasional lymphoid aggregates within the interstitium. And the higher power, can you, next slide please. There are subpleural honeycomb change as well. So overall, mild degree of honeycomb change, but no granulomata, and the normal alveoli are noted in between the tissue reaction. So overall, temporal heterogeneity is noted. So considering the temporal heterogeneity with inflammation and fibrosis and the subpleural honeycomb change, it's a chronic interstitial pneumonia with honeycomb change, and the probable diagnosis is UIP with some lymphoid aggregates within the interstitium also.
Can I just ask you if you saw fibroblastic foci?
Yeah, very few foci of fibroblasts are noted within the interstitium.
It's relevant because we happen to know already that the patient was alive at least 5 years later, and in various forms of UIP, a lower profusion of fibroblastic foci on average goes with less progressive disease, I think. So you feel this was classical UIP. Okay.
Thank you so much. That's very interesting. And then I'd like to ask from the audience, what is the likely diagnosis here? If you could hands up, please, if you are telling it is IPF or if it is IPF less likely. Would you mind, hands up if it is IPF? All right.
Nobody's going to point a finger if you put your hand up.
Yeah.
You're not going to be burnt at the stake.
Right. Yeah. IPF likely, less likely? Yeah. The first, if you could hands up, if it is likely. Okay, we have 2, 3, 4. Okay, we have 5, 6.
They're
7.
secret hands. They're just up a little bit.
And the next, if IPF less likely. Right, okay, we have 1, 2, 3, 4, 5, 6, 7. Okay, it's about 50-50 at the moment. Right, so then I'd like to invite Prof. Wells to discuss the clinical likelihood. I mean, ignore the CT scan and ignore the biopsy, just with the history and with the basic investigations. I'd like if Prof. Wells could discuss the clinical likelihood of IPF here, using this diagram.
Well, you very obligingly put this slide up, which was from a perspective that I was part of, assigning likelihoods. You're really asking two questions here with this presentation. Do you think it's UIP? And we've got the answer as it happens from a biopsy, but I strongly agree that in somebody age 60, female lifelong non-smoker, the likelihood of IPF is definitely lower than the classical likelihood. And you're in a gray area. Now, if she was 50 to 55, I would have said, firstly on the scan, probably fibrotic NSIP was more likely. But by the time you're up to the age of 60, it's gray area. Female, lifelong non-smoker. Well, we happen to know that there is UIP. That was what you were asked about. And I think on balance, somebody of this age, the greater likelihood would be, even though we're not given clues about hypersensitivity pneumonitis or clues to suggest connective tissue disease, one of those two pathologies is probably a little bit more likely than IPF. I wouldn't have said IPF's out of the question, and she might turn out to be the first member of a family with IPF, where you will often see younger disease. So it isn't out of the question. In the bell-shaped distribution of IPF, it remains possible. I think the odds probably are about 2 to 1 that either this is an occult connective tissue disease or it's one of those hypersensitivity pneumonitis cases with a UIP phenotype, plainly doesn't have the classical CT features, and we are talking about a minority group of HP patients, but they do tend to be the patients where you don't find an antigen.
Thank you so much. And in 2022, yeah.
If you can go back to that slide, I have a question for Professor Wells. You've added familial aggregation or aggregation of fibrotic ILD as a point to differentiate likelihood, increased likelihood of IPF or not. And I worry because at least in India, where hypersensitivity pneumonitis is a common disease, you find familial aggregation because they have the same exposure to that offending agent, whichever it is. And so I wonder if in that particular instance this would hold true, because I know here we're trying to talk of genetic susceptibility, but
it can be environmental susceptibility.
Right.
I think that's a delicious comment, actually. And I would, in a European setting where you don't have a huge amount of HP compared to India, I would stand by that. But in India, you might very well be making a crucial point that the association is environmental rather than, although I think in general these diseases are both genetic and environmental. So my gut feeling is outside India and possibly outside Mexico, where there's a huge amount of HP. This statement is probably correct, that a familial aggregation is pointing you towards what we call familial IPF. Now, that's a bit of a paradox. It's familial and yet it's idiopathic, but familial IPF.
Thank you. This patient in 2022, in fact, she developed some inflammatory type arthropathy involving bilateral knee joints. And at that point, they have done the rheumatoid factor, which was positive in high titer, and reviewed by the rheumatologist, and they diagnosed she to have rheumatoid arthritis, and then offered disease-modifying treatment with methotrexate and leflunomide. So when we are thinking back about this patient, so he has definite UIP pattern in the biopsy, and some probable UIP or fibrotic NSIP pattern in the CT scan. But in fact, this patient has some clues of CTD in the biopsy. Would you mind discussing, Dr. Ramani Punche, about these possible CTD features of these lymphoid aggregates that which we don't see in...
Can you put the third slide?
Yeah.
Yeah, this is the aggregate of lymphoid aggregates within the interstitium. Usually, if I see some aggregates of lymphoid cells, usually I suggest for the autoimmune screening, but unfortunately, this patient, initially those were negative. So, but there is some clue of this CT-related ILD.
Thank you. And also that, so because of the economic constraints, we are doing very limited autoimmune screening, and particularly ENA and CCP, anti-CCP antibodies at the disease onset, whether that could have helped in this patient to prevent going for a surgical lung biopsy. Professor Wells, what do you think about it?
It might have. It really depends on the nature of antibody positivity. So you're not going to do a myositis screen because the scan doesn't remotely look like lung disease with inflammatory myopathy. You don't at this stage know it's UIP. I think you would definitely do a full ENA screen in somebody late 50s, age 60, female, lifelong non-smoker with that scan. I do agree that expanding the rheumatoid serology would be helpful. You're really asking a different question, though, because you know it takes 6 years for the clinical manifestations to develop. So my instinct is that it's probably unlikely that you will get the serology 6 years before the clinical disease manifests, but it's possible. Now, the other question in that case, I think it's still worth knowing then that this patient has UIP, but I think if you had serology that was more diagnostic, so let's suppose SCL70 positivity or convincing rheumatoid serology, you would not do a biopsy at this stage. So in summary, I don't think you would have got the serology, but if you had got the serology, probably you wouldn't have done the biopsy.
Exactly, yes. Yeah. Thank you. And then this patient had, so as this patient was treated with antifibrotics, pirfenidone, and she has fairly stable lung functions.
I just want to look at that lung function in a bit more detail, because there's an important clue here. Yes, so for IPF, before this connective tissue disease declared itself, this was highly atypical serial lung function for IPF. Look at this. You're going down from 58.9 to 52.7 over 5 years. And already at that stage in 2016, with a gas transfer of 42%, that's a moderately severe lung function impairment. You really should not be alive unless you've got a far better response to an was this patient on an antifibrotic from the start of this? So I suppose it's within the spectrum, but when you see this very slow decline over 5 years, I think it's actually really quite good even for a patient treated with an antifibrotic drug. So I suppose one thing you might have thought about, which we would think about and do some of the time, is to repeat the autoimmune serology after what was slow progression for about 4 years. I'm not saying I know you should have. It's one of those 50-50 calls.
Then she had another CT scan in 2021 and 2023. I wonder if you could comment on them.
That's the one you showed before, isn't it?
This is 2021. Initially it's 2020, and then the next one is...
The one in 2021, let's just start that. Yeah, I don't think I can. We'll just wait for it to scroll. And again, we can see these reticular opacities here, non-dependent. But if you remember the earlier scan, there is progression of disease. And now here you start seeing honeycombing in the superior segments and then even further in the basal segments as well. So if I can freeze this, here we've started seeing an increase in the traction bronchiectasis, increase in the reticular opacities, and increase in the honeycombing. So this tells us that there is progression. It fits in with now with the honeycombing into a UIP pattern, and given the history of rheumatoid arthritis, we could call it RAILD with a UIP pattern. But more importantly, there's progression of disease.
Okay, and there's another CT scan in 2023, but it is the same, and there's evidence of some progression, no change in between. And so then, at the end of this multidisciplinary meeting, I'd like to ask from Professor Wells, what would be the consensus ILD diagnosis now, and what is the degree of confidence that you have in terms of the diagnosis, and are you entertaining any other differential diagnosis now, and what would be the disease behavior that we could expect in future, and then whether we should do anything else for her management?
Okay. The consensus, well, this patient does have rheumatoid, does have UIP, and therefore we're going to end up calling this rheumatoid lung. Now, what I will say is there's a debate right now as to whether rheumatoid causes the UIP or whether patients get IPF and this causes rheumatoid. And that's the debate. Now, what is interesting here is that this patient had fairly serious interstitial lung disease 6 years before the rheumatoid developed. And there is an argument that rheumatoid arthritis in general begins with events in the lungs. And my colleague Gisli Jenkins has mounted an epidemiology study, and he argues for IPF sometimes causing rheumatoid. But I'm going to call it rheumatoid lung because there is rheumatoid arthritis with interstitial lung disease, and I'll leave that argument out of further discussion. And I'm confident there's rheumatoid on what I've heard, and I'm confident there's UIP. So you are confident this is definite rheumatoid lung, whichever thing came first. And once I've said this about that uncertainty, I haven't got a differential. Expected disease behavior, you're already talking on the edge of experience with antifibrotic drugs, aren't you? Because you are now at 7 years of treatment. And so far, you don't seem to lose your potency with time. But I did notice that the latest lung function had moved a bit more quickly. And maybe the scan has changed a bit more recently, but we don't have the first scan. So cautious optimism. And finally, the rheumatoid is recent. You're going to have to manage the systemic disease anyway. I suspect you're going to end up with combination therapy. And with the rheumatoid having developed recently, there may be some point in protecting the lungs from immune dysregulation. So I would be going for a low dose or gentle immunomodulation, or asking the rheumatologist to choose the best systemic treatment for rheumatoid, and then reviewing what that treatment is to see if it fits in with lung management. You've got to wheel and deal with rheumatologists, don't you? Yeah. And some of them you can wheel and deal with very easily, and some of them are more like used car salesmen in my experience.
Exactly.
So there is a genuine variation. Heavens knows what they say about interstitial lung disease, doctors.
Exactly, and in this patient, the rheumatologists, they decided to start on methotrexate and leflunomide. As we know, I mean, leflunomide potentially can cause some pneumotoxicity in certain group of patients. Methotrexate, the evidence for pneumotoxicity is getting low and low now. But having a patient with this fibrotic lung disease and fairly preserved lung volumes, but starting a potentially pneumotoxic drug, do you have any concerns over it?
I think that the conversation you're having with the rheumatologist, seriously now, and I work with brilliant rheumatologists, the conversation you're having is, are you sure you need to use 2 drugs that might be pneumotoxic? Now, of the 2, I'm far more comfortable with methotrexate, and I don't think anyone would have said that 5 years ago, but methotrexate has been rehabilitated. Nonetheless, there are the much rarer examples where it does cause an aggressive pneumonitis, not the sort of UIP pattern we've been talking about, that's been discredited. So I'm more comfortable with methotrexate, provided the rheumatologist says to me, look, it's important we use methotrexate. Not happy with azathioprine. They're not that happy anyway with mycophenolate, are they? And then you might be talking about rituximab. But I suppose it's the leflunomide that gives me really quite serious reservation. And it's one of those discussions you have to have with a rheumatologist, and you have to hear from them why it's crucial they should use both methotrexate and leflunomide.
Thank you.
So you are negotiating.
Yeah, we are
So
going to negotiate.
My rheumatologist calls pulmonologists cowboys.
Yeah, and often your rheumatologist is right, but one or two of my colleagues will call rheumatologists wimps, but I'm sure that they're all wrong.
And also, I mean, I know this question I should have asked from the rheumatologist, but again, now there's emerging evidence that, I mean, the biologics, particularly abatacept, coming into picture. I know it's a fairly kind of new drug that some new evidence is coming through. Ideally, and we should have to have rheumatologist here, but what is your experience regarding abatacept in this sort of situation?
I sit in a multidisciplinary meeting once a month at another hospital with a great rheumatologist, Chris Denton. And we've negotiated abatacept occasionally in patients. It's quite hard to access. There isn't funding support for it, and that's the only reason. Look, this patient, if abatacept's going to meet the needs of the rheumatologist, I think it would be a very, very good treatment to introduce. It's all based on a lot of observational work, but if you want to pick impressive observational work, this drug is top of the poll, I think, in CTD-ILD, just based on observational work. I think you're negotiating, first of all, what's the imperative here? Is it management of the lung disease, or is it management of the systemic disease? And sometimes you can decide who calls the shots. Now, this case probably is a 50-50 call, so you do have to negotiate. And I'm waiting to hear the justification for leflunomide.
We'll update you soon.
And you say that chest physicians are cowboys.
So just a quick update on methotrexate from you. A lot of people have a lot of reservations, and while we've been trying to tell pulmonologists and rheumatologists that methotrexate doesn't cause a fibrosing ILD, clearly it does have an acute, subacute effect on the lungs. So throw some light on it.
Yes, it's really quite rare. And you now tap into people like Chris Stent, and you can tap into my experience. And I think the number of patients, bearing in mind methotrexate was quite wisely used in rheumatoid, the number that had the convincing inflammatory pneumonitis I can put on the fingers of one hand. Now, if you get that, of course, if you're starting with a low reserve, it's not a good thing to get, but generally you can retrieve that. It's not, however, so much that, it's that a lot of clinicians just don't want to believe that methotrexate doesn't cause fibrotic lung disease. And there's a very plaintive editorial in one of the rheumatological journals bemoaning the fact that clinicians don't seem to want to not believe in methotrexate causing lung fibrosis after all of the studies that have now come out.
Thank you. And
Indeed, there's some evidence to suggest that methotrexate could just be the best second-line agent to deal with interstitial lung disease amongst the family of immunosuppressive drugs.
So a little interesting aside is I also do some lung cancer work, and when I'm sitting with the oncologists, they're super cowboys when it comes to drugs, And they don't care about methotrexate and the lung and its effects on the lung, and they just poo-poo it away. So it's mainly on the rheumatology, pulmonology side. But the oncologists use methotrexate anyway and anyhow they want. I mean, that's pretty much how it is. So.
I think it takes clinicians 5 to 7 years to read the literature by the time you have all clinicians taking things aboard. We're in a lag phase now on methotrexate.
Thank you so much. And I'd like to involve the audience if there's any burning questions here that we can ask from the team. And yeah, any comments? Yes, yes, sir.
Probably a rheumatologist.
Unfortunately, no. A cowboy. Right, so thank you all the panelists for the important points that were discussed. My question is to Dr. Jankaria. We hear about this anterior upper lobe sign, straight edge sign. How important are these signs, and are they specifically associated with any type of rheumatological disease like rheumatoid arthritis? And should be looking at sagittal sections also in patients whom we are suspecting connective tissue ILDs?
Okay, so the question was how important are the anterior upper lobe and straight edge signs, and should we be looking for them, and do they make a difference? If you talk about high quality studies in terms of randomized control or even high quality observational studies, we don't have those. But like in a lot of radiology, you're basically using signs to point towards a certain set of diagnoses. So you don't always need that kind of high quality evidence. But in my routine practice, every day when I see an interstitial lung disease, and I'm scrolling on my workstation, I'm looking at the sagittal and coronal images in every patient. And if I see a straight edge on the coronals, I will call it, because if the patient is not, so if I see a straight edge in an 85-year-old smoker or an 80-year-old smoker with everything else being classic, I may call it and then not make a big deal about it. But if I see it in a 65-year-old non-smoker, where now you're borderline, we're not talking of a 45-year-old woman where it's almost always going to be a CTD-ILD. But you see a 60, 65-year-old with a straight edge, let's say in a patient like this, then you're going to mention it to say that there are findings that point towards the possibility of connective tissue disease, ILD. The anterior upper lobe sign is perhaps even more specific, because we really see it only when there's CTD-ILD. And it is supposed to be more common in rheumatoid arthritis and scleroderma, but I'm assuming that it does occur in the other CTD-ILDs as well. But in our practice, RA and scleroderma are so much more common than the rest of them that we just see them. So the bias could be that we just see them a lot in RA and scleroderma, because we see a lot of RA and scleroderma. So,
Thank you.
But they're important signs, yes.
Of the two, would you say more common in rheumatoid or more common in scleroderma?
Rheumatoid.
Yeah, and having scored something like 500 scleroderma scans, I do have to agree this fits very much with my experience. Some of the large scleroderma cohorts, I was a score of 4 that were published in Radiology quite a while ago. On our rheumatoid experience, yes, absolutely. It's quite common. It's exuberant honeycombing. The change from striking abnormality to normal lung. And some of those patients have remarkable preservation of gas transfer. So when you don't have straight edge, I think you're seeing the tip of the iceberg on CT. But when you move from striking abnormality to normality, one suspects that what you see on CT is what you have, and the rest of the lung is probably functioning well, and the DLCO is often surprisingly well preserved.
So one more question. So,
Dr. Ravin.
This is to Professor Wells. So this lady was on pirfenidone for the last 5 years. So in retrospect, would you have started her? I mean, is that the correct decision at the outset? And would you continue that as well now?
Firstly, I would, using what I know now, I would have wanted to start an antifibrotic. I'm not allowed to in the UK unless I diagnose IPF. You can only use an antifibrotic otherwise if you have progression during follow-up. And even if you don't treat a UIP because you think it's unlikely that therapies that are traditional will help a UIP, you still have to demonstrate progression. So if I was practicing somewhere without those rules, I would have said yes. UIP outside IPF, with the possible exception of scleroderma, where it's a rare form in a rarer disease, but in rheumatoid, other CTD, vasculitis and HP, the outcomes in spite of traditional therapy seem to be identical to IPF. The trail trial of pirfenidone seemed to show in rheumatoid UIP a striking treatment effect based on serial FVC. Yes, I would want to use an antifibrotic from day one in this patient. And my dilemma would have been, I think it's more likely that it's not IPF, so do I add cautious immunomodulation to cover the differentials? And that's a more difficult question. I think if I was getting a strong lead from the biopsy, and I'm not sure how strong the lead was, that there was likely to be a connective tissue disease, I think I would use combination therapy from the outset. Look, you're starting with an FVC, it's as low as 60% in somebody aged only 60. I don't want to miss an opportunity. So I would probably use or want to use combination therapy. In the UK, I'd have to start with immunomodulation. And when there's progression, add an antifibrotic drug.
Thank you.
Thank you so much. We'll move to the, yeah.
So my question is from Professor Wells. This is regarding, so now we have a definition for CTD and CTD-ILD, and we have IPEF, definition of IPEF. And then we have patients who have features of autoimmune disease and ILD, and who they don't fit into the diagnosis of diagnostic criteria for IPEF and CTD-ILD. Those patients, how do you decide on immunosuppression?
Well, first of all, I've had enough of IPAF. So I think we've got to make a decision that it is or is not a diagnosis. We can't go on indefinitely calling it a research entity. It's fine to do it to begin with, because you are actually calling for studies. Now, we've had the studies. You can't own this and hold it as a research entity when half the world is calling it a diagnosis and the other half is calling it a research entity. And within IPAF as a designation, there's a lot of variation in how convincing it is that you have a connective tissue disease. Look, our diagnosis is multidisciplinary. We don't define HP and insist that you have to meet exact criteria or you definitely don't have HP. And if we're going to use multidisciplinary discussion to decide on things, we should be using it to decide on CTD. I would say that meeting IPAF criteria is a good starting point for multidisciplinary discussion, but there are things that IPAF criteria don't capture. So, for example, if a patient develops an inflammatory arthralgia, sicker symptoms which are convincing, which, by the way, are not allowed in IPAF, new reflux, which is not allowed in IPAF, you've got arthralgia but not arthropathy, they all develop at the same time, and you get a lung disease developing at the same time. common sense will tell you this is likely to be a connective tissue disease, but you don't even meet IPAF criteria. So I'd say two things. Firstly, it's time we made IPAF a diagnosis, but that diagnosis should be made by multidisciplinary discussion. And it should take aboard in individual patients all of the features. And if you start meeting formal IPAF criteria, that should just be a starting point, where you then review the whole patient. But the final diagnosis of IPAF is multidisciplinary. And we can't go on with half the world calling it a research entity and half the world calling it a diagnosis. And your management depends on how confident you are that you're dealing with CTD-ILD.
Thank you so much. And let's move to the next patient. And I'd like to invite Dr. APD Manodya to present this case.
Yeah, the next patient we are discussing today, she's a 46-year-old female from Katunayaka, and she's a mother of one. She initially presented in January 2022 with a history of dry cough, exertional dyspnea for 5 months duration, and it was associated with symptoms like loss of weight and loss of appetite. And along with that, she also suffered from mechanical type joint pains, mainly involving bilateral knee joints as well as left elbow joint. So initially she underwent HRCT chest, and according to the findings on the CT, she was started on steroids, initially 30 milligram daily. And as the initial EBA samples were inconclusive, however, they have sent for TB cultures and TB was excluded. And apart from that, there are some significant points in her history. She had a history of 4 first trimester miscarriages, but there are no other features like skin rashes or any other connective tissue features in the history. And above symptoms were not associated with any chest pain, wheezing, or any history of fever. And apart from that, she had no history of red eyes, polyuria, polydipsia, and there were no past or contact history of TB as well. And there were no history of recent travels, any risk sexual behaviors, and no other system involvement clinically. Apart from that, she had exposure to textile dust for about 10 years duration, and that was 5 years before this initial presentation. And she has no family history of ILDs. On examination, there were no significant findings actually. There were no clubbing, no skin rashes or any other CTD features on examination, and there was no clinically palpable cervical or axillary lymph nodes, and respiratory examination also unremarkable. And along with the CT findings, CTs, she underwent basic investigations including full blood count, that was normal, and CRP was also 4.6, which is normal, and ESR was 54. And her liver functions, renal functions, electrolytes, and also the TB screening, including the MAN2 test, all were negative. And she underwent this serum total calcium, which was 9.1, again in the normal range, and serum ACE levels, it was also 32, which is again in the normal level. Rheumatoid factor is 20, and other investigations like 2D echocardiogram, that is also normal. Initial PFT shows the TLC of 69% with FVC 2.3, which is again 68%.
Thank you so much. So we'll discuss the imaging now. I would invite Dr. Jankaria to discuss initially the chest X-ray and next the CT scan of this lady, please.
So I think the radiograph shows bilateral hilar lesions, and there are a lot of these opacities which also have a perihilar distribution. If you were going for an exam and you were asked to make a spot diagnosis, or as we call it in radiology, give an Aunt Minnie, then this is what you would typically see with sarcoid, and then they would probably, the examiner, depending on how sadistic the examiner was, would say which scadding grade it is, and then you would probably say stage 3. and then move on with it. But luckily these days we also have a CT, and I'm going to try and see if we can play the video. Can you play it from your side? Because I don't, here, okay, I think we've got something. So if you look at this, I'm not able to pause this. So if you can, okay, I think I may have some control here. No. Are you able to play it at your end and control it? So if you can just get to the hilar regions, I think we have very classic findings, and I can just show them here. No, all right. So if you see here, right, you see these perihilar nodules. There's obviously hilar adenopathy. This is a very, very typical pattern of sarcoid. So we've got beading, we've got fissural nodules, all of that. And I don't think there's a doubt to the diagnosis. That's pretty much sarcoid.
Thank you so much. And so again, so this patient in the clinical context, again, if I summarize, a young lady presenting with cough and shortness of breath with the background of loss of appetite and loss of weight, and she has some mechanical joint pains and some increased fatigability. So radiologically, this is suggestive of sarcoidosis, but as a clinician, I mean, do you happy with the diagnosis, or do you want to consider more investigations here? I'd like to ask the question from the audience. I mean, if it is sarcoidosis, pure and simple, please raise your hands. And if you're investigating, if you're thinking something else on top of sarcoidosis or any other differential diagnosis, please raise your hands. Option 1. Okay, okay. Apart from sarcoidosis, is there anything else going on? Right. Yeah, okay. So I think because we are in a background of we are in not very high, but it is indeterminate, increased prevalence of tuberculosis in our setup, especially a patient coming with loss of appetite, loss of weight. They are typical symptoms of sarcoidosis, but I think we might have to think about TB as well. But anyway, I'd like to invite Professor Wells to discuss.
Not sure I'd want to be examined by you. Let me start with that comment. Look, in London and a non-pandemic area, I know exactly what I would be saying, and I would nail the radiologist. I would go to them and say, are you saying there is no plausible differential diagnosis? And in a non-TB pandemic area, I would combine that with this presentation. And then I'd have a conversation with the patient, and I'd say, hand on heart, look, there are many people who still think a biopsy is compulsory. My view is that sarcoid is more than 95% likely. We have two approaches with this. We can now demonstrate with your disease behavior that there's no reason to doubt the diagnosis. But I'm saying up front it's not quite 100%, so if you feel you must have a biopsy because I'm telling you that, then I would arrange that, but I would support a decision to manage this case as sarcoidosis at this point. Now, I mean, you have a lot of patients that aren't as classical, and you have to guide patients that you do need a biopsy, but to these eyes, this scan looked so classical. I couldn't see, and I asked you this before, that there was a plausible alternative diagnosis. Now, I'm here to learn at this point that in a TB pandemic area, is it conceivable you could have both processes going on producing that scan? Because if you were to tell me that was so, I would say get a biopsy and culture the biopsy material.
So in many instances, I think we can be quite sure that it's purely sarcoid, and you do not have any CT feature that points or tells us otherwise. There's always a small percentage of patients who might have old TB, and especially in the upper lobes, which can change the appearance of the rest of the findings? And then if you were to ask me, could there be associated reactivation of tuberculosis along with the sarcoid? I wouldn't be able to answer that question, and you'd have to figure that out. And then sometimes you actually see active TB with the tree and bud at the periphery and central sarcoid occurring at the same time. Or if we've given contrast, we might see non-necrotic lymph nodes, typically of sarcoid, and then you have an axillary node that's necrotic, or a supraclavicular node that's necrotic. So you can get different patterns, and we have to accept the fact that all of these can happen in our setting, and just be cognizant of that fact, and then report all of the findings that we have. Yeah.
I think I get from this you would be comfortable in not performing a biopsy in this case, but you have to come back case to case,
Yes.
even if you think sarcoid is the favored diagnosis.
Yes.
Thank you. And this patient, in fact, had a transbronchial, he had this repeat CT scan has been done after 1 year that showed some evidence of progression and persistence of symptoms of cough and shortness of breath and fatigability. A transbronchial biopsy has been done. So I'd like to invite Dr. Punchihewa to discuss the transbronchial biopsy for this patient.
The low power view of this, the two fragments of bronchial mucosal tissue. The submucosa contain very few, about 3 non-caseating granulomata. And these, the typical feature of this granuloma, they are very small and discrete. And the other thing, they have less lymphocytic cuff. Usually in TB, you get the lot of lymphocytic cuff around the granuloma. But in this one, 3 small non-caseating granuloma with less lymphocytic cuff, and other classic picture is the perigranulomatous fibrosis. So all features favor the sarcoidosis that TB. In setting of TB prevalence in our country, usually I ask always to correlate with the TB culture results.
The high power?
These are higher view of the some small granuloma at the center and the either side with less lymphocytes and fibrotic stroma.
Thank you, madam. In fact, this patient had cultures which has been sent from the biopsies, and continuously, initially they have started her on steroids. Initially started with prednisolone 30 milligram daily, and they try to kind of wean off steroids, but whenever they try to wean off that, she again present with symptoms like joint pains, fatigability, and cough. And even though I'd like Professor Wells to comment on the lung functions and then discuss about the steroids, particularly in a setting of preserved lung functions, but the patient is symptomatic, and the main reason for the steroids could have been the symptoms of fatigability.
Well, what I don't want to do is give the talk I'm going to give tomorrow on practical approach to sarcoid, so I'll keep this brief. The spirometry is slightly obstructive, and we see this a good deal in sarcoid after all. We don't know if it's a mixed defect without the total lung capacity, which I don't see. No. So we don't know if it's an obstructive defect or a mixed defect. I wouldn't be surprised if it was mixed. So the lung function pattern is what it is. Now, the gas transfer is quite well preserved, and at least in our analyses, and I hope you see this in the literature shortly, 3 cohorts of 1,400, 1,400, and 400 stage 4 cases. It's gas transfer that signals damage and danger, and the threshold after which you have an IPF-like survival compared to a brilliant survival is a gas transfer threshold of 40%. But I don't imagine that 39 is radically different from 41, and you don't want to treat after the train has already left the station. So I get worried about danger when the gas transfer drops below 55%. There's an FVC effect that's about 60%, and that would slightly be my concern. So you're looking at risk thresholds. An FVC below 60 is not as dangerous as a gas transfer below 40, but this patient's dropped to 69 in just 6 months. So I would protect against damage without going to a high dose for danger. So the two reasons to treat are danger in terms of mortality or future permanent disability and unacceptable loss of quality of life. Now, it sounds to me like this patient has unacceptable loss of quality of life.
Patient has developed some cushingoid features and...
No, at the outset. You're making
yeah.
a decision at the outset as to what you do. And I don't think you go high-dose steroid for unacceptable loss of quality of life, because you have a net effect in loss of quality of life due to steroid side effects. And so to me, there's not severe danger, but there's enough to make you happy that you're going to try to treat quality of life with gentle therapy, which you think will also serve to protect the lungs. That's how I see this. And then, unlike danger, where you go to the traditional high doses, quality of life, you're making 20 different deals with 50 different patients. How much do they tell you that they must have some treatment? They don't want to just accept loss of quality of life and avoid steroid therapy. You've got to be very cognizant at that point that quality of life, there's only one world expert in the room about the patient's quality of life, and that's the patient. So in this patient, I would be going for a gentle approach if I'm satisfied that this patient has such loss of quality of life that it would be a great shame not to find out if quality of life was transformed by civilized therapy. And I would like the fact that the civilized therapy was in place to protect the lungs in the first stage of the illness. I don't think I would go to that sort of dose of steroid, because you wind up, whenever you reduce the dose, you naturally get more fatigue with steroid reduction, and people think that's worsening of sarcoid. You've got some osteoarthritis, you'll suppress that with steroid. When you reduce the dose, your osteoarthritis will flare up. So I'd be inclined to go to low dose, and keep in mind that fatigue usually does not respond to steroid or second-line therapy in sarcoid. So you can use high-dose steroid, it won't control the fatigue, but when you go into steroid withdrawal, the fatigue will get worse, and the patient will tell you, I can't stop the steroid because my sarcoid keeps coming back.
Yeah, thank you so much. So again, I think we don't have any concern. Yeah.
One quick one. So in many parts of the world, they believe that, so this patient had serum ACE levels that were normal, and we are making a diagnosis of sarcoid, but many physicians I work with would then specifically do a biopsy or want confirmation because they believe that ACE levels must be elevated in patients with sarcoid. And I know that that's not really true, but what light can you throw on that?
The light is that many clinicians are dead wrong. So sarcoid patients, probably about half of them express ACE, half don't. And I don't think a normal ACE helps you in the slightest. In fact, in my experience, ACE tends to be strikingly positive in those patients where you don't need diagnostic support. When you most need it, ACE is frustratingly absent. So I think if your ACE is very high, that is helpful. Now, there's obviously differentials to that, and tuberculosis, unfortunately, is one of them. But nonetheless, if you're sure you have excluded tuberculosis, I think a high serum ACE can be a support for sarcoid. In a non-TB pandemic area, I think it's more useful. But a normal ACE really doesn't help you in the slightest.
Thank you so much. And also I'd like to ask you about, if you go back to the basic investigations and when you see the full blood count, in fact we can see that the lymphocyte counts are relatively low in this case, even though it is low, towards low side. Is there any connection of lymphocytopenia with disease activity?
There certainly is. Probably a lymphopenia is the most prevalent blood test abnormality going with sarcoid activity. You expect it. And it shouldn't inhibit you if you do need to use an immunosuppressive drug. Plainly, you monitor a bit more intensively to begin with, but it shouldn't put you off. I think the other thing that's worth saying, you come to a patient, you're asking, is there danger? And that danger has to include proactively looking for cardiac sarcoid, asking about palpitation. I do a BNP quite frequently, ECG, and if there's any doubt in the matter, you absolutely have to pursue cardiac sarcoid. And that's especially true when you've got lung disease, because cardiac symptoms like dyspnea will be put down wrongly to the lung disease. You've lost some of your signal clinically that there might be cardiac disease. So you're looking proactively for danger, and while you're doing that, you're saying to the patient, I'm just checking there isn't danger. We haven't got the results yet. I want you to take the next 2 to 4 weeks, day by day, to work out how bad is your loss of quality of life, because we're going to talk about this, and you've got to take a view on this. You've got to help me out in deciding on therapies for loss of quality of life. And in the end, we're going to work out a deal, but you're going to have to make some co-decisions on this. Just keep a diary or take note. How bad is my life day by day for the next 2 weeks? And then I can give you the danger news, and we can work out an approach which is about your quality of life.
Thank you so much. And I'd like to invite the audience, if there are any questions or comments we'd like to discuss in this forum, please.
We've got half of tomorrow's talk.
Yeah. So looking forward to listening to your talk, Professor. And we are going to...
Can I ask an off-track question, right?
Just for a change.
Yeah. So I was in a tumor MDD, and they showed a patient who had nivolumab-associated lung disease.
Sorry, what?
Nivolumab, an immunotherapy drug. Right. And it was bad disease, and the oncologists, along with the pulmonologists, started nintedanib in the patient as an antifibrotic on an acute basis. And I argued, but I'm a radiologist, I'm not supposed to open my mouth. And I said, there is no data, no evidence, and we have no data ever that any antifibrotic can reverse anatomic disease. What is your view on something like this?
You have to tell me a bit more about the drug reaction and the setting. Was this malignant treatment?
Yes.
For a lung cancer?
For a lung cancer.
For a biologic?
Yes. An immunotherapy drug was used. There was significant lung involvement acutely, and the patient was dyspneic, had to be admitted, was ventilated, and was not responding to regular treatment, even though the nivolumab had been withdrawn. And then the question was what to do next, and they just threw everything at the patient, including...
Okay, so I've had a long talk with Philippe Camus, who's very much a guru. I took the disease behavior classification to him, and he came back with examples of all 5 patterns, and one of them is inexorable progression in spite of withdrawing the drug, and in spite of using what you use, an IPF-like course. Now, you will have looked at scans before the drug reaction, and our literature suggests that an IPF-like course usually means you've got subclinical UIP on a scan.
No, it wasn't.
And that wasn't there in this case.
It was an acute lung injury.
Understood with a clean scan before, because a lot of that lung injury is in the context of a limited UIP pattern.
No, it wasn't.
It
No,
wasn't. So
no.
that's important. So you're really using an antifibrotic drug because you believe it might influence lung injury. And you're quite right. We just don't know the answer to that. Now, we have a sense in real-world and clinical trial cohorts when you combine them that antifibrotic drugs almost certainly reduce the prevalence of lung injury in IPF. So that is almost certainly the case. And by the time you put together the trial cohorts and you take aboard the real-world data, I think it's quite convincing. Now, do you apply that to lung injury without the background IPF? We don't know.
So you could take
So
a
I
chance.
could understand how you could use that precedent. You could say this patient's in trouble. Unless you find a way to change the outcome, it's going to be bad news. But I wouldn't be arguing for doing this myself on what I know.
All right, thank you so much. And I'd like to thank the faculty, Professor Wells and Dr. Jankaria and Dr. Punchia for the great contributions. And I'd like to thank our colleague consultants, actually, Dr. Amit Fernando, Dr. Saman Kulratna, Dr. Shant Peran, Dr. Ravini Karunatilak, and Dr. Vatsala Gunasingh, because all these patients are, we have 5 cases that we prepared for this MDT, and then we screened 2 best cases out of it, and then the senior registrars who helped immensely to produce this presentation. And thank you so much.
Moderation. Thank you.
Yes, it was. But next time, we don't sit side by side. I need to see you. So I can see what's coming.
Thank you very much for that very informative and interactive session. And now to present the tokens of appreciation to the speakers and moderator of the roundtable discussion, I cordially invite consultant chest physician Dr. Amita Fernando on stage. Dr. Bhavin Jankaria, Professor Athol Wells, Dr. Ramani Punchiheva, and the moderator, Dr. Amila Ratnapala. Thank you very much.
Thank you, chairpersons and speakers. Ladies and gentlemen, so that brings this day filled with dynamic sessions to an end. We thank all the participants who joined us today amidst their busy schedules. We'll recommence tomorrow's sessions at 7:30 a.m. We cordially invite you to enjoy the tea, which is now served outside. Until then, have a pleasant evening.